Welcome to Raise the Line with Osmosis from Elsevier, seeking solutions with leading experts on how to increase healthcare capacity so people can get the care they need during the pandemic and beyond.
Hi, I'm Shiv Gaglani. Grace Wilsey was born with a genetic disorder so rare that at the time of her birth, it had never been identified in a single individual. NGLI1 deficiency involves a single mutated gene, but it causes a wide range of physical and cognitive problems, including muscle weakness, speech deficiencies, and seizures. Grace's father, Matt, is with us today to share the journey his family has been on since her birth in 2009, which includes starting a foundation and a biotech company that are fueling research into NGLI1 deficiency that could have an impact on more common diseases such as cancer and Parkinson's. The researchers involved include Nobel laureates Jennifer Doudna, Shinya Yamanaka, Brian Kobilka, and Carolyn Bertozzi. And before we get started, I'd like to thank former Raise Line podcast guest Chelsea Clinton, who speaks so highly of Matt and his family. And Matt, it's a pleasure to have you on.
Thank you so much for having me. It's a real pleasure to join you.
Awesome. So we like to first start with getting some highlights of your personal and professional journey before becoming a parent.
Well, it's I joke that I'm a jack of many trades and a master of none. So I wore many hats really before I got into biotech. I started actually in government, in public service. I had, since the earliest moments of my life, I remember just wanting to get into public service and to work on something that was really larger than myself, to help as many people as I possibly could. So I trained as an undergrad to get into government and worked on a national presidential campaign, worked in the White House and worked in the Pentagon. And I joke that I wanted to see how the biggest, most bureaucratic organizations work so that I could then apply the lessons to the startup world and what not to do, maybe. And I went back to Silicon Valley after those tours were done and helped start a couple of different tech companies in Silicon Valley. And I really loved it. I felt, though, if I wanted to be a successful CEO and leader someday, that I needed to go back to business school. So I went back and got my accounting training, macroeconomic training, HR training. And I thought, I'll try my hand at private equity. Business school is a good time to pivot. And so I went to New York and did private equity right in the worst possible time, probably in 2008, as the world was on fire. And I quickly realized I wasn't very good at it. I prefer to be an operator. I like to build things and be involved from day one, sort of building and nurturing a team. And came back to Silicon Valley and started two more tech companies. And around that time is when Grace arrived, and it sort of, I would say, kind of derailed all career plans and trajectories.
Yeah, no, I can imagine. I mean, just being a parent and then obviously with Grace's diagnosis. So let's go into NGLI1 deficiency. Our audience, obviously they are healthcare professionals and students, but part of our focus on rare diseases is because they often don't even learn about these deficiencies until they meet a patient. And oftentimes that patient may take years to get diagnosed, as you well know. So can you tell us a bit about NGLI deficiency? What causes it? Why does it cause so many systemic issues? And then we're going to go into Grace's personal story.
Yes, yeah. So it's an autosomal recessive disorder. So most of the audience will know that she had to inherit two bad copies of the gene, one from me and one from Kristen. Really just kind of unfortunate luck. We had a 3-year sort of diagnostic odyssey. And because there wasn't a lot known about the disease, and I think sort of the timing of it, whole genome sequencing and even whole exome sequencing wasn't largely available. And so this disease in particular was a little bit hard to pin down. It was misdiagnosed as mitochondrial disease X or Y, cerebral palsy, these catch-all buckets that the medical community kind of wants to attach a label to. And in a lot of ways, it's beneficial because you get services through that. But NGLI1 is really one of the most highly conserved genes known to science. So it's fundamental to life. You can find it in just about everything. And what it's really doing in humans, and it's ubiquitous. So it's in every cell in the body. It is responsible for the proteasome bounce back mechanism. So as the cell is under stress, oxidative stress or other kinds of stress, you need the proteasome to step in and help the cell recover. Basically, NGLI1 is there to help that process. It's almost like a firefighter that's on call, just sitting in the fire engine, ready to go when there's a problem. Without that there, the cell just kind of overwhelms itself with stress and starts to die. And the primary place where it's most affected is the central nervous system, the CNS. We also see other issues in the liver and the eyes, and the peripheral nervous system as well. But the CNS is really the primary hub that we're trying to address. And that's really where our first drug is going to go to.
That's amazing. Well, thanks for that explanation. And again, like you describe this impressive background you have from government, from business, and again, any audience member who tunes in, can mistake you, and for good reason, as a bench scientist, just given how well you know this, because again, that's a common theme with all of our rare disease guests, is they know the business really well, or the medicine really well underlying the condition. So tell us about Grace, about the Diagnostic Odyssey. How's Grace doing, and how is it showing up?
So I would say overall that she's well, she's stable. And I say that with a bit of trepidation, because we have lost a number of patients over the last 2 years. Our global community is roughly 100 patients that have been identified. And we're probably at about 80 to 85 that are diagnosed and living at this point. So we've lost 9 in the last 2 years, either to COVID, long-term COVID, or I often think of a kind of a broken heart, because these patients are largely nonverbal, and they're very social. And so without that element of being able to interact with teachers or therapists or friends at school, there's really not that same fight to keep living. But for Grace overall, I say she's stable. She's very happy. She's very social still. She's back at school, thankfully, with the vaccines. The things where the disease really manifests itself for her every day, she's fully dependent on care. So toileting, bathing, dressing, feeding. She has a G tube. She has a lacrima, so dry eyes because of the loss of NGLY1. So we have to put in drops and ointment constantly. So honestly, if she was born maybe 50 years ago, not even like 100 years ago, she probably wouldn't have survived the birth. And so now, as we see as these patients get older, certain things are continuing to break down or fall apart much faster than they would in a typically developing child, or even a child or one of us as we age. In a lot of ways, Kristen used to identify when we would go see clinicians. She's like, it's almost like she's got baby Parkinson's. You try and attach a label to it to kind of frame it for them. And those kind of clues I think are really important, I think, for clinicians that are watching.
Yeah, no, absolutely. That's and that'll definitely come back, that analogy of baby Parkinson's, because certainly the work that you and Grace Science are doing could have implications to that far more well-known and common condition. So, you get this diagnosis, obviously things are confusing and going wrong with Grace, with the 3-year Diagnostic Odyssey, and a lot of parents or loved ones of these patients who have these rare conditions turn that anxiety, that fear, that heartbreak into something positive. And you turned it into the Grace Foundation and Grace Science. We've heard that from people like the Fulmers, who we had on, the EB Research Foundation. You may know them. John
Yes.
Crowley, obviously pretty well known. David Feigenbaum, who also Chelsea Clinton's backing on that. Tell us about your story. Like, how long was it until starting Grace Foundation and then Grace Science, and what's the difference between the two?
Yes. Yeah. So, I even remember it was an emergency C-section, and Kristen was full term carrying Grace. And I've never seen the red panic button hit faster in my life than that. The doctors and nurses were running all over the place, basically taking Kristen's clothes off in the hallway as they were rushing her down. And I was just given a chair because I couldn't get my scrubs on to go in the operating room. So I was just sat outside, and I just honestly, I prayed to God. I just said, just get them both through this, and I will do whatever it takes to develop a cure. And so I felt like that was my obligation to keep going forward. And initially we funded just through our family. We would write checks to like Stanford or to Baylor in Houston. And it might be 1 or 2 principal investigators. And we just said, we're going to fund you to do X or Y. And some other family and friends said, we'd like to support. And they would write checks to those same centers that we had sort of vetted. But what became clear is that we could raise a lot more money if we took on the responsibility of truly vetting and managing these organizations day in and day out, making sure that they were staying on track, holding them accountable, almost like a business, more of a business than a foundation or just outright donations. So we started the Grace Science Foundation, and so far has deployed about $10 million, which obviously is not much for developing a cure, but it's a lot when your disease is starting with $0. Yeah. And we wanted to build the Manhattan Project. Essentially, what we've seen in COVID and that mobilization is what we were doing years ahead of time for Angli-1 deficiency. It was like, get the best and the brightest in the world working on this disease and see what happens. And I knew that we just kind of had to be patient and wait for that one breakthrough. And that really came through Carolyn Bertozzi, who was one of our grantees. And she sort of flipped the script, and we said, okay, this is our aha moment. Now we have to start a company, because that's really what's going to take these discoveries and translate them into humans.
Yeah, no, that's fascinating. And again, turning that fear and heartbreak into something so positive. And 10 million, obviously, from zero is incredible, especially when it comes to something that right now we've only identified 100 patients with it, but again, the underlying science is fascinating. So can you tell us about kind of the research with the prestigious group of collaborators you have? How is it going? Are there promising developments both for curing it, but also just treating the symptoms?
Yeah, there's a lot of promise. So we've tried to get as many lines in the water as possible. And this actually was one of the early lessons from John Crowley, who has been a mentor, which is the first therapy probably isn't going to be the end all be all. We're going to probably layer on top other therapies, especially as the patients age and new things evolve. You have to attack with those phenotypes. We really believe that the number one way that we can help these individuals is by delivering a gene therapy directly to the brain. So we've developed over the last few years a AAV9 gene therapy that we've done a tremendous amount of animal testing, and we're actually submitting our IND to the FDA tomorrow. So we're hoping to be in the clinic early next year in 2023, and it can't come fast enough. We're trying to push as hard as possible. But beyond that, we have, I think, some other exciting therapies that are kind of coming, backing up in the pipeline that I think will have some good potential for these patients and beyond.
Yeah, tell us about some of that. I mean, because that's one thing in our conversation with the Fulmers on epidermolysis bullosa. They're very hopeful that in the next 5 years there'll be a cure for it. But similar to what you've described, it's putting multiple lines in the water, because you don't know. You need to do things in parallel. You don't know which ones will work, and hopefully we can find one of these things will work. So what are some of the other things that kind of excite you that are coming down the pipeline?
Yeah, I mean, the thing for Angli-1 deficiency specifically, there are some small molecule potentiators and small molecule inhibitors that are, really enticing. The thing that obviously keeps me up at night there is, what are the off-target effects? What are you helping, but on the same side, what are you potentially hurting? Because we fundamentally believe in the do no harm mantra. I think a lot of rare disease advocates such as myself might get mistaken for moving too fast. And the fact is, we have the greatest incentive to make sure that the drug is max safety. It's very different than another type of organization that is not living with the patient. But the thing that really kind of blew my mind is Carolyn Bertozzi's work that really opened this whole new world for us. It's like I joke that we were stepping through the looking glass. I mean, we just didn't even know this world existed. And initially we thought Angli-1 was just sort of a boring housekeeping gene. And she was the first to sort of say, no, this is actually more fundamental. This is really responsible for handling cell stress. And that's where we knew that it was really a gateway, almost a Rosetta Stone, probably for multiple oncologies. And we are working now on a small molecule inhibitor for cancer. And, it's still not going to be in the clinic next year, but we hope in the next couple of years that it will be. And it gives us a lot of hope, not just for the patients that started this, that is really our North Star, but how does this impact millions of people, potentially millions of families? And that gives us a lot of incentive and motivation to keep going on the hard days. You just can't give up. And if we don't pursue this, no one else is going to. And so we really want to be that spark, and then look for partners that can help us take it, beyond our expertise.
Totally. And part of the kind of the benefit, I think, of investing in these rare disease research studies, apart from obviously the number one thing being, grace and families and patients affected with NGLY1, is the potential impact that the research itself can have on other more common conditions. So the examples we often cite are statin development from research in familial hypercholesterolemia, or tocilizumab, which was developed for Castleman's, being very useful for severe COVID-19 cases. Tell us a bit about maybe the science and I mentioned cancer, Parkinson's. How come the research that your team is doing, or funding at least, can impact to such disparate types of diseases, or seemingly disparate diseases?
Right. And I like to think I think often, so I'm dyslexic, so I think oftentimes in terms of analogies. And I think of NGLY1 as almost this airplane engine. It's like controlling the 747 engines, and we can throttle it up for more power. And in that case, we would want it for neurodegeneration, and we want to actually throttle it down, or maybe off completely in the case of cancer. And it goes back to that cell homeostasis. Sometimes the cell needs more, and sometimes the cell needs less or very little. And maybe that's for just a short period of time. And so that's really what we're trying to dedicate a big part of our team now, is unlocking this. And, it's funny, so Grace is 13. When she was 12, I went to 100 investors or donors, and I said, rare diseases unlock common diseases that we as a society are probably spending billions of dollars on every year. I think I might have gotten like 1 out of 100 to agree with me. If I do that same conversation now, it's like 99 out of 100. It is shocking how fast. I mean, it's like, you hear the story about baby aspirin and how quickly that was adopted by, cardiologists and general practitioners. Like it took something ridiculous, like 17 years, right? In this case, the idea that a rare disease unlocks a common disease, it happened lightning fast. And we're not even scratching the surface of what's potential, not just with NGLY1 deficiency, but every rare disease. And there should be, in theory, 20,000 rare diseases, right? If you think about every gene could be a rare disease. We're not even halfway there in terms of identifying these diseases and then understanding what's the hub and spoke from those hubs. So I'm super excited about it, as you can tell.
That is really exciting. And you're actually the first guest we've had on who's actually made that full connection, because we often cite 7,000 plus rare diseases. And some people say 10,000. Clearly, 20,000 genes, and there's someone in the world, we may not have met them, may have been born in rural Uganda, we just can't reach them yet, who have a rare disease we've never even heard of, and being able to help them, but then unlock common, as you mentioned. Our audience at Osmosis used to be just health professional students primarily, as well as patients and family members. Since we joined Elsevier a year ago, we now clearly have a large audience of researchers. And one of our hopes and what we've been able to do is kind of make this research more accessible, trying to open access a lot of rare disease research. And that includes our CEO, Kumsal, who's been super supportive of the initiatives we've done in rare diseases. What advice do you have for researchers and clinicians when you talk to them, both about, say they stumble upon a rare disease, like they listen to this podcast or they watch a video on it? What advice would you give to them about even entering this space and maybe dedicating their careers to helping rare disease patients and family members?
Yeah, I mean, the first thing I would think that comes to mind is, one, thank you. I mean, we all so appreciate what you're doing. It's often a very thankless job. And with another NGLY1 dad, we wrote an editorial for Nature. And in that, I close by saying, there's people like me that are dreaming about finding you, and we just don't know where you are. And so try and seek out, the outliers like Grace. And what our experience has been that, especially our experience with American doctors, is they go above and beyond. They don't just go the extra mile. They go like an extra 25 miles and on top of already very busy and hectic schedule. And there's so much pressure And we see this at Stanford and other major clinical centers where it's either like focus on, number of patients in the clinic or focus on research. It's very hard to do both. And with that pressure, it's just kind of like you're just moving A to B or A to C. It's just like, very meat and potatoes, and try and sprinkle in a few of these outliers, or maybe it's just one outlier like Grace that can truly change science and medicine. And it could potentially change your career. It could be something that you're now the world's expert in. And it's really amazing how one little case like Grace's has shaped so many different individuals throughout science. And I think it will have profound effects long after she's gone. And so my sort of leaving moment for all the scientists and clinicians, researchers that are watching is find those outliers and try and nurture those relationships, because it's really amazing what can happen.
Totally. Yeah, that's a very much a common theme. And we had one of my guests that I love having on, Philippe Pachter, whose daughter Lizzie Ann's 5 has Pierre-Robin sequence, said something similar where, obviously anything a clinician or researcher does is very mission oriented and good for humanity as a whole, and there's patients that they see and treat. But oftentimes, it's like the difference between curing a million people who have a headache versus 10 people who have cancer, right? Something much more devastating generally than headaches. And so the gratitude you get from the patients and family members, that sense of purpose, being able to put a name, put a face, put a story to what you're doing, and then have that race against time, which adds that urgency, because it isn't like, oh, it'll be cured in 50 years. You want to do it now. It's truly motivating. And that's something we recommend our listeners take full attention to as they're deciding what career, how to dedicate their career. Spend a summer, spend a year, maybe a career at some point researching these conditions.
Yes, absolutely. And it's almost like Google kind of made this famous where they had, 75%, 80% of your day is technically your job, the activities that you're supposed to get done. And then the balance is just pie in the sky. Where can this lead? And I know there's a lot of different pressure for a clinician or researcher, especially with tenure and other things, and publishing is the name of the game. But there still is opportunity, I think, to nurture these, even at a very small, even if it's like 5% of your time, it can really have a huge impact. And I think it's very rewarding personally.
Totally. And my hope is, again, foundations as well as centers of excellence will cultivate this, clearly, because by you bringing together this group of people for the Grace Foundation and funding researchers, now they have the money to, dedicate, and, can talk to their tenure board about the work that they're doing. As you know, Osmosis is a teaching company. We like to fill in knowledge gaps. And one question we like to ask our guests is, if you could snap your fingers and teach any group of people anything, what would it be and why?
Well, there's a couple things that come to mind. And one of them is, I don't think there's a solution yet, but I would challenge people to think about what that solution is, which is manufacturing. Cell and gene therapy manufacturing is very, very expensive. And if we were able to figure out a way to do that faster and cheaper, it would accelerate, I think, therapies and cures more than just about anything that's out there right now. These therapies work, and it's still early, right? It's not perfect. We can get better vectors that are transducing a higher percentage of cells. We can improve the empty full ratio within AAV. There's a lot of things. That would be one of my biggest ones, which is, how do we do this faster and cheaper? But the other thing is biomarkers. At the end of the day, biomarkers are so fundamental. And you see this debate that's going on, with the FDA right now on some of the more larger diseases of, is this biomarker actually measuring success or not? Things like the 6-minute walk test just don't work for a lot of diseases, especially these rare neuromuscular diseases. But a drug could work and the biomarker shows it, but the FDA or others might say, that's not good enough. And at the end of the day, what else do we have to offer these patients? We can't just let them go home and die. And so somehow we need to do a better job educating on biomarkers, and not only discovering them, but proving them. I think is really a key 1-2 punch.
Those are two really good examples that you shared. And certainly when I was in med school, we weren't being taught about either of these things much, but every year it's exponential gains. I mean, I'm sure you've kept in touch with, we had a guy, Brett Copeland, whose daughter you may know has epidermolysis bullosa, and he's very involved in policies around cell and gene manufacturing. And here at Elsevier, we do a lot of like in silico bio. That's how David Fagenbaum and I got in touch, where it's trying to speed up even like identifying what targets could be what drugs could be repurposed for which targets, just based on AI and models, computer models for where we should look. And you know this better than I do. You're in Silicon Valley, so you obviously probably keep in touch with all those developments.
Exactly. Yeah. I mean, and again, I think we're barely scratching the surface. And that's the hard thing with the war in Ukraine, inflation, COVID, a lot of those things really screeched to a halt, or slowed down dramatically. And so getting those back and operational again, I think is super important. And, and a lot of investors sort of thought rare diseases were cool and sexy, and they've also stopped funding there because they've gone into hunker down mode. But, kind of going back to my tech entrepreneur days, this is the absolute best time to start something. The troughs are where you really see great companies started. So if you have a great idea, get out there, start it.
Totally. Yeah, exactly. That's great advice. So I know we're at time, so I did want to leave you with one more question, which is there anything else that you want to get across to our audience that I haven't asked you about yet?
Gosh, not that I can think of. I mean, I would say that it really does take a village, honestly, like not just on the clinical and the research side, but it's people like, brainstorming with John Crowley or a David or any of these guys, the EB team. It is so fun. It's so fundamental to our success. There's no way we would be where we were or are right now without those people like really kind of supporting us. And I hope that we do the same thing for them. And the days are tough. It's hard to get connected with these families, and then the patients die. But just kind of keep pushing that envelope, I think we're just really, really so important in supporting each other.
Absolutely. I think that's great advice to end on, and the importance of having this strong community. That's one thing I've just learned, having been interviewed wonderful people like yourself over the past several months, especially, is how well connected and supportive they are with each other. Even though the conditions are very different, maybe the causes are different, it does, the saying, a rare is one, which I know Tanya Simoncelli and, the folks at CZI, Heidi Bjornson-Pinnell, are supporting. So Matt, I really appreciate you taking the time to be with us, and more importantly, the work that you do, not only for Grace, but for any family who has a rare disease, and bringing together these researchers and clinicians in the way you have.
Well, thanks so much for having me. It's great meeting up. Hope to do it in person next time.
That'd be wonderful. Well, thank you again. And to our audience, thank you for listening. Remember to do your part to raise line and strengthen the healthcare system. We're all in this together. Take care.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelinepodcast.